Communication and documentation. We're going to look at radio procedures, the times that you're looking for, what you say on the radio, who you talk to. We're going to look at the format that we're going to use when you make your radio report. You know, after you're treating a patient, you're transporting them to the hospital, you have to call the ER and tell them you're coming. You have to give them a quick report about your patient. So you got to be ready to do that. Once we get at the ER, we're going to have to turn over patient care to the nurse or physician. So we have a procedure for giving them that run report. Who all do we communicate with in the course of our jobs? We talk to dispatch.
Patients.
Police and
Patients.
police.
Police, fire, certainly. The people at the hospital, the ER.
Bystanders.
We make bystanders.
Possibly the college.
Family members.
Yeah, those would be the fire department, police, family members. We covered everybody? No, let's go more. Our partner, we talked about the ER people. One more, what is it? You know, we may have supervisors at work, people like that. And we communicate with a whole bunch of people on a whole different levels. So we're going to talk about that. We're going to talk about the contents of our pre-hospital care report. Shot you. Bad, huh?
You have to get some EMS treatment.
I know. Y'all thought that I had to leave my gun in my car. Surprise. Okay, we're going to look at the legal aspects. The legal aspects of documentation, because we do carry a heavy legal burden with that. And also, we've already talked about patient refusals, but we have to make sure we document those. So, I talked about all those. Let's get after it. Okay, we use radios, we use cell phones, we don't use pagers so much anymore. Does anybody use a pager anywhere out there ever? Well, you do. What do you do with it?
Well, we have them at work.
Really?
Yeah.
You can say use it like for a doorstop or paperweight or
Well,
something.
when someone pulls their cord, it pages.
Okay. Okay. That's a non-traditional pager. Yeah, what? Yes. Some kind of pager. Yeah.
Most law enforcement will use pagers.
Do they?
Don't doctors have pagers?
Pagers
They do on Grey's
pagers with
Anatomy.
service. Like everywhere a cell phone doesn't get service, a pager does.
So there is some use. In EMS, I don't see them. I haven't seen one for years, but maybe they still use them around here. Then, of course, there are some landlines out there left. And you may use those if you're in a patient's home and you're way out in the sticks somewhere. They may not get cell service, so they may have a landline. Okay, the EMS system, there are several components of the EMS system as far as communication. We have a base station. Any idea what the base station would be? The D word? Dispatch. The dispatch center. That's going to be the base station. That's where all the big guns, not really big guns, but all the big equipment stays. We've got mobile radios. Where would a mobile radio be found? Attached to the truck, yeah. So in the ambulance, it's attached in the ambulance, and the ambulance moves around. That makes it mobile. How about portable radio?
Like your radio.
Yeah, you carry that with you, yeah. It's like one of your weapons. What's a repeater?
I don't know.
Yeah. It's like a little tower, kind of like a little cell tower, but it's not a cell tower. And it boosts the signal from your little portable radio so you can get it back to the base station or wherever it's going. Microwave transmissions, who knows what those are? I cooked popcorn tonight. That's the extent of my microwave knowledge. Digital radio signals, everybody had to get digital television so we could have good radio signals. But often, most of our stuff is transmitted by digital right now anyway. This is a little schematic. This is, what kind of radio's on here? The mobile. And this would be so the mobile radio sends its signal to the repeater. The repeater picks it up, sends it possibly to another repeater, to the base station, to dispatch, whatever. So yeah, they boost the signal so it can get around. Like in a mountainous area, which is not this area, even though they call that the valley up there. Why do they call that the valley?
Maybe it used to be a valley.
That would indicate there are mountains around it.
Yeah, I know. Maybe they got, done worn down or something.
Yeah, but that was before people spoke English.
Well, I'm saying maybe.
Hey, bro, we dug them up and we shipped them off the
Oh,
chain.
did you? Because you're not two thousand.
The
Outsourcing
mountains
our
or the valleys. Anyway, in a mountainous area, they're going to have a lot more repeaters, or if their district covers a wide area, they're going to have repeaters in there to boost their signal, which is good. EMS communication is regulated by the FCC. What does that stand for? Federal Communications Commission. That's right. And they regulate what we can do with our radio, what we can say on our radio. So what I'm saying here is only say things on the radio that you don't mind your mom hearing, or your 3-year-old cousin that's going to repeat everything that you say. So they're going to have a license. There's going to be rules about appropriate language, and they monitor our radio traffic. Okay, when you're using your radio, make sure you've got your volume turned on appropriately. Make sure that you're not on the 50-yard line during the middle of the Auburn, who did we play last week? Mississippi State game, trying to radio for help while everybody's screaming because we just scored a touchdown. So you got to be cognizant of the noise going on around you. Now, our radios, our portable radios, have a little push-to-talk button. How many of you guys use that? What is that system that goes? Nextel. Yeah, it goes click click. And
Sure.
yeah, it chirps. Yeah, thank you for that. But you have to hold that button down because if you start talking right away, like as you're pushing the button, you're going to cut off your first word or two. So you have to press the button, wait about a second, and then start talking because it's going to cut you off and it might be inappropriate. When you're talking, you don't need to put it down your throat. You just kind of hold it out here a little bit. You don't need to go click, click, click like that. So everybody's going to hear it. When you're speaking, make sure you enunciate. Speak clearly. If they can't understand what you're saying or they get it wrong, then you could have a real problem going on there. So make sure that you say it very clearly and that you're understood. Many times you may want to repeat back to the person so that it's particularly if it's real and crucial information, so that both of you understand that you know what you're talking about there. You usually will say the unit number first and then whatever it is you want to tell them. Because if you just throw it out there, say, we're en route to a fire, unit 378, all they hear is route to a fire. So you want to say who the unit is first and then whatever your communication is. Now, if you're calling another unit or you're calling dispatch, if they're busy, they may tell you to stand by. That's okay. You just wait. Because only one give and take can go on at a time. You might have 10 ambulances out there and they're all coming and going and got this going on and that going on. They all want to call a dispatch center. They can only communicate with one unit at a time. So you'll have to wait till that one's finished. Why is that important? How does that impact your communication, the fact that they can only talk to one unit at a time? Well, that part's good. They're paying attention for sure. If they can only talk to one unit at a time, and you get on there and you giving the history of the day and what's going on, what else is happening out there? They're all backed up waiting for you to get off the radio so they can say shots fired at their scene, or the roof has collapsed, or we've had an accident, we've rolled over and we've got 5 patients. So anytime you're on the radio talking either from unit to unit or to dispatch, you want to say the important stuff, say what you got to say, then get off. You want to speak slowly and clearly? Keep it brief. You want to use plain English whenever possible. In an area like this, particularly, Lee County is surrounded very closely by a bunch of other counties. I moved here from Baldwin County, which is about half the size of the state, so it wasn't a problem. But here, you've got so many counties, and every county has their own language and their own little set of 10 codes. Their codes are all going to be different, so it's important that you use plain language so that people across the county lines can understand you. It's rude to say, be advised. Don't say, be advised, we're getting 5 inches of rain right now. It's very rude. So if you need to call in and say you have a delay because it's raining, just say, Unit 378, we're delayed for heavy rain. You can't see, we're going 5 miles an hour. And you don't need to get into please and thank you and that kind of stuff. That just takes up airtime and space where you may have people that have emergency that need to get on the radio. So always be polite, speak clearly, but not with a lot of fluff. If you don't understand a number, you may spell it, not spell it out, but just say 101 for 101 to make sure that you get the digits right. Never use a patient's name on the radio. There are a lot of people out there in scanner land. They'll have scanners and they can pick up radio transmissions. So you want to make sure that you don't violate somebody's rights by using their name or any identifying information over the radio, if you can prevent it. I already mentioned this, kind of no profanities or slander. And you should know not to do that anyway, but sometimes accidents may happen where somebody has accidentally depressed your call button key and you have a live mic and you don't know it until you've said some really detrimental things. That's the voice of experience speaking. So always make sure if you're going to say anything, it's like before I say something, I always look around and make sure that the cameras aren't on or the recorders. So make sure that you don't have a hot mic in your ambulance. When you're using a radio, just say we're en route. Don't say I'm en route. Using affirmative and negative is much more clear than yes or no. Even today, most people don't say yes and no. They go, yeah, yeah. I never know what that is. So affirmative, negative is fine. If you're going to say yes and no, make sure you enunciate that very clearly. You don't have to say over. Avoid slang or abbreviations. People don't understand that. In this day and age, people move from one area to the next, and they may not be familiar with where you're going or where you are, the names of your streets. If you're using, down there by Grace Service Station. So make it very clear where you're going and what you're up to. Only use the radio for things you should be using the radio for. Call your friends because they're on the next truck, get on the other line and do that. Just don't do that. Now, if you've got two units that are trying to broadcast or transmit at the same time, they're only going to pick up one. Sometimes you may not know that right away. You think you've given your report, but they've never answered you back. You think you've called dispatch, and you give them whatever it is you need to tell them, and they don't ever tell you that they've copied it, then they probably didn't. So you may need to check that. They will usually let you know that they've received your transmission. Now, we might not say copy. We might say 10-4 or something, but they usually will let you know. And sometimes they'll just give you a timestamp, to let you know they've heard you. They'll say, 2438 or something. Anytime you leave the truck, you need to take your portable radio with you. That's required. I understand that there may be some services in the area where they don't supply a radio for each crew member. Do you know anything about that, John? Anybody? Yeah. Each crew member needs to have a radio. If you get separated, and that happens very commonly, you're at a wreck scene, you go check on these patients, I'll go check on these patients. You each need a radio so that you can communicate. Yes?
As far as all those
I was in a situation one time where we responded to a plane crash. And of course we each had radios. And my partner was so jazzed about this plane crash that he jumped out of the truck and ran off into the woods because the plane had crashed in the middle of these woods, big woods. And I looked around and his radio sitting right by me in the truck. He didn't take his airway bag. He didn't take a first aid kit. He didn't take gloves. He just took his little old self and went running into the woods. So what don't I know now? A, do we really have a plane crash? Do we have any patients out there? How serious are they? Is there anything else that we need? What do I need to do? Stand there going, why don't you take your dadgum radio with you? So always take your radio. And make sure it's serviced and make sure it's got a battery in it that's charged. You don't want to get a mile into the plane crash and there's no charge in your radio. You must phone a report to the hospital before you show up. There's nothing that cranks them any quicker than to show up at the hospital and you've not told them you're coming. What this means is you may stay out in the ambulance bay and phone your report and say we were just around the corner and then drag your feet a little bit because they will beat you up very badly. So make sure, even if you have to call before you leave the scene, you know, we're 10 minutes out, or the patient, blah, 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 will be there in 10 minutes. They need to know, because why? Why do they need to know? They've got to get ready. If you've got a serious patient, they might need to round up some more staff. It could be they're slammed and they don't have a bed, and you come in with somebody in cardiac arrest. So you're really gonna bend them out of shape in a hurry. When you call in to the hospital and make your hospital report, you only want to give them pertinent information. If you've got a patient with chest pain, do you want to tell them that they had their appendix out 2 years ago? They will kill you when you get there if you do that. All they want is the patient stable or unstable? You know, are the vital signs within normal limits? If not, what have we got there? Anything pertinent. The patient's been defibrillated 3 times, you know, from cardiac arrest. Well, that's important. So they need to know the important stuff, not the unimportant stuff. Parts of your medical report, now you'll give most of these, but you may not give all of these, depending on how stable they are or not. They want to know what your unit number is, you know, your unit 378, or I don't know what they call them around here, or something. And if you're anything but an ALS crew, most places expect you to be an ALS crew, that's advanced life support. But if you're not, if you're on an EMT truck, they need to know that. Because if you roll in and they're expecting you to have an IV in place, they expect you to have given some drugs or doing some advanced care, they need to know that you're not going to be doing that. So they need to be ready to do that. They want to know when you're going to be here. If you're 20 minutes out, they're going to say, call me in 10 minutes. A lot can happen in 20 minutes. So they usually want you to call anywhere from 5 to 10 minutes out. And each hospital may have different parameters. If it's a major trauma center, you know, just tell us you're coming sometime before you hit the door. If it's a community hospital, they may not even have the physician in the hospital. He may be asleep somewhere, or he may run over from his private practice down the street. So they definitely want to know. So find out how your local hospital operates so that you can fit within their parameters. So when you call it, they want to know the patient's age and sex. You know, if you have a patient that's 78 years old, he's got chest pain, that's real different than a guy who's 22 and has chest pain. You know, who they're really going to worry about here. The old guy with chest pain is probably having a heart attack. The young guy's probably having a panic attack. And that's narrow, but, you know, it looks like a duck. So they want to know the age and the sex and what their chief complaint is. This is Unit 378. We're en route with a 67-year-old male, chief complaint, chest pain. Or we're en route with a 67-year-old male with chest pain. So I've already done 2 or 3 of these all at once. Give a brief history. He's reported chest pain 8 out of 10, which started approximately 20 minutes ago. He's had open heart surgery twice, open heart surgery, and he's on these medications. We've given him nitroglycerin, oxygen. His pain has decreased somewhat. We'll be there in 10 minutes or something. You'll give mental status if it's anything but normal. Based on vital signs, most of the time, if they're within normal limits, you'll say vital signs within normal limits and roll on. They only want to know if he's got a blood pressure of 200 over, 110 or something. If you have any pertinent findings of your physical exam, he's got bilateral femur fractures. Yeah, they want to know that. Any emergency care given. If you've given him nitroglycerin, you want to tell him. If your patient's got anaphylaxis, we've given him epinephrine ×2. Response to medical care. Is he getting better or is he getting worse? And then if you need to talk to medical control at the hospital, and you may need to do that, if you need orders for something, then you would want to do that. So you kind of go loosely in this order. You don't have to give all this information, but this is the information that they would want, provided it's pertinent. And I will tell you, it's difficult to give a radio report. You know, you're really worried about getting all your patient care done, covering all your bases, getting everything done, and now you got to call them and tell them what you've done. And of course, the first thing they're going to zero in on is what you forgot to do. It's like we give nitroglycerin for chest pain patients, but we want to make sure we've gotten a blood pressure, because why? The blood pressure actually usually drops when you give nitroglycerin, but we're not going to give nitroglycerin unless the blood pressure is at least 90 systolic or above. So if we call in and say, wait, doc, I want to give my patient some nitroglycerin, first thing he's going to ask you is, what's his blood pressure? And you don't want to have to say, I didn't get it yet. So you want to make sure that you've covered all your bases before you call in for that. When you're talking to the physician at the hospital, you want to be very clear, you want to enunciate properly, you want to give him the background that he needs so he can make a decision about whether you can give that drug or not. When he gives you orders for something, say, yes, I want you to give up to 3 nitroglycerin tablets, you want to repeat that back to them. Say, okay, sir, you said up to 3 nitroglycerin tablets, provided the blood pressure stays above 90. He'll go, yes, that's what I said. If he orders you to do something that's inappropriate, you have a patient say that say you're asking for some nitroglycerin, he goes, no, just give him some oral glucose. What? Excuse me, my patient has chest pain, he's got a blood pressure of 110/80, he doesn't take any erectile dysfunction medications, I wanted to give him his nitroglycerin that's prescribed for him. He'll probably say, oh yeah, I'm sorry, I was listening to something else. Yeah, give him nitro. So you want to make sure you repeat it back to him. If it's inappropriate, you want to question him on that. They're always going to be on a recorded line, so know that anything you say is going to be recorded, anything they say is recorded. So that's for your protection. So it's always a good thing. Almost always. Okay, your verbal report at bedside. This is when you get at the hospital. I always like to ask at bedside if whoever I'm giving the report to, if they heard my initial radio report. If they heard my initial radio report, then I don't really have to cover all of that ground again. But if they didn't hear the first report, then I really have to start over. Now your bedside report, you want to start with an introduction of your patient. More times than not, you're going to know the nurse or physician that you're turning over patient care to. So you'll say, Miss Jones, that's my patient, I want you to meet, Rhonda, she's the nurse that's going to be taking care of you. So you want to make sure you introduce them. Because even a short amount of time that you spend with your patient, they kind of develop a bond with you. It's just you and your patient for 10 minutes, 15 minutes, 30 minutes, maybe an hour. And if they're in a real stressful situation, they have really bonded with you. And so trying to peel them off and turn them over to somebody else can be a challenge for both of you, more so for them than you. So make sure you introduce them and make the patient feel comfortable about who you're turning over care to. And then give them a good detailed report. Not everything like they had their appendicitis taken out last year, unless they just really like that kind of stuff. You'll document that in your patient care report, and you will leave a copy of that either at that time or you're legally required to return it to the hospital within 24 hours. So you do have to complete it and give it back, but you're required to give an oral report with all the pertinent information at bedside.
Do you usually always keep a personal copy of your report?
Legally you can't keep a personal copy of your report. Legally you're not supposed to keep any of that stuff. So the idea is to write a very good, thorough report. It becomes part of their permanent medical record, and your service or your state will keep a permanent copy. So you'll pretty much always have access to that if you need it. But yeah, they tell you shouldn't keep a copy. Have I kept a copy? Yeah. Occasionally if I know there's something that's probably going to come back to me, and usually I have a pretty good idea of most of those that are going to come back, if it's a crime scene or something of that nature. If I don't keep a copy, I'm going to make really good notes for myself, because if you ever do get called, the more information you can remember about it, the better for you. But yeah, that's a good question. Okay, your detailed report, of course you want to tell them what the chief complaint was, if they have any, what the history of the present illness. Patient says he's got chest pain, 8 out of 10, radiating to his jaw and down his arm. He said this has been going on for about 30 minutes. He's not taken anything for that. He didn't take any aspirin or nitro. Once we got there, we gave him nitroglycerin and aspirin and oxygen. You want to make sure you tell them any pertinent negatives. We talked about pertinent negatives in here. That dull look tells me no. Pertinent negatives, that doesn't sound familiar to you? Okay, well it is now. You might go ahead and write that down somewhere. A pertinent negative is something that you may have expected to find, but you did not. For instance, if you have a patient with chest pain, he says, yes, I've got chest pain. You say, where is it? Right in the middle of my chest. Does it radiate anywhere? No. That would be a pertinent negative. It would not be unusual or surprising for him to say, yeah, it radiates to my jaw and down my arm. That would be expected. So it would be a pertinent negative that he says, no, it doesn't radiate anywhere. A pertinent negative for a patient with chest pain, you would ask him if he has any respiratory distress. And he says, no, doesn't hurt when I breathe, I don't feel short of breath. That would be a pertinent negative because it's not unusual to find a patient having chest pain to also have shortness of breath. You have a patient with congestive heart failure, and during your assessment you check their ankles, and you see their ankles are not swollen at all. There's no pedal edema. Pedal is going to be down at the ankles and the foot. There's no edema or swelling in that area. That would be a pertinent negative. So that would be something you would want to be sure and document. Patient has chest pain but denies shortness of breath. That would be a pertinent negative. And you absolutely have to record pertinent negatives because one thing that says about you is that you looked for it and you asked about it and you assessed for it and it was not there. It was absent. So you absolutely have to record your pertinent negatives. And I do know you will have questions on National Registry where they want you to identify the pertinent negative. They'll give you a scenario and they'll say which of the following would be a pertinent negative. And so you'll read through those and identify that. So we'll look at these as we roll through the semester. So you want to make sure you tell them any treatment that you gave them. They need to know you've already given them 4 baby aspirin because they don't want to turn around and give them 4 more baby aspirin. That could be detrimental to your patient. So they need to know what you've given them so they can move forward from there. Of course, you want to give them a complete set of vital signs. You wouldn't do that over the radio, only if something is outside of norm. Here, even though they're normal, you want to give them so they can document the baseline vitals that you came in with. Questions about that? Okay, let's look at interpersonal communication. This is going to be between people, the people that we were talking about that we communicate with. We communicate with anybody and everybody that has anything to do with your patient and patient care. We need to always be respectful and we always need to be calm. Many times you're going to have family members, patients, bystanders, other people on scene that may be very upset and may be very cross. It's important that we're always respectful and we're always calm. And I can't emphasize the importance of being respectful. We work with a lot of other agencies, and as soon as you start getting snotty or rude or disrespectful to any member of another team, that will come back and bite you down the road. We all work in this business together, and there are going to be times where you need law enforcement. You need the fire department. And if you've treated them rudely or been disrespectful, how quick are they going to be to come to your rescue? I haven't finished my breakfast yet. I don't think I'm going to be rolling on this call just yet. So it's important that you're always respectful. And I've seen this many, many times, particularly with first responder crews and your ALS crew comes on scene. They're there. They work in that community. They know those people. And oftentimes that family, that patient knows that first responder, and there's a bond there. And if you come in and treat them disrespectfully or rudely, that's really going to put your patient off. Now, they don't have any respect for you. But the biggest part of this is you're going to need them down the road. And if you treat them ugly or disrespectfully, they will make you pay for it. I know that because I've made them pay for it before. They also usually have a lot of information about your patient, some stuff that you might not have even noticed or collected. Oftentimes they're on scene for 10, 15, 20, 30 minutes before you get there. So they may have a lot of information. Now, I think I mentioned to you before, when you get your vital signs, you're going to get your own set of vital signs. I'm not really too concerned with the first set of vital signs that maybe somebody on scene may have gotten, because they're going to get them differently than I do. But I'm going to be respectful about that. I'm going to take, if they've written it down, I want that piece of paper. I want everything they can give me about that patient. They may have some obscure thing written up here, the patient is allergic to morphine. Now, y'all not going to be given morphine, but I might. And if they're allergic to morphine and, you know, and I'm not even thinking and I don't ask and I shoot that patient up with morphine, you could kill them. So I've got something there that may pull my fat out of the fire sometimes. So always be respectful, get the information that they're going to give you, and then make sure you collect your own information. Communicating, they call this therapeutic communication because you're communicating in a very important way because you're having to treat a patient. So you need to get as much information as you can at the time. You got to recognize that the people around you may be freaking out. I mean, they are totally out of control, and you have to get information from them. So you have to be calm. You have to be very direct. You have to look at them and say, I really need your help here. I need you to calm down so I can get some information. So some people may have to work on their communication skills. If you're one of those people that have anger management issues, you're going to have to work on that. Because if you start getting angry because your patient is angry or a family member's angry, now who are we really going to need to come and help us? Probably the police, and you've been rude to them, so they're not going to come. So your patient's family is going to shoot you. Yeah. So communication is very important. Some of the things you can do that will help establish good communication is going to be eye contact with your patient. Make sure that they recognize that you're interested and you care about them. If you walk in the room like this, like, why don't you call me today? How much good information are you going to get from your patient? This is where you give the big goose egg. They're going to be turned off and put off by that, by the way your demeanor and your attitude, and they're not going to tell you anything. You take them to the hospital, and they're going to spill their guts to the nurse. Now how do you look? The big S word. That's stupid. Exactly right. You look really stupid. And you place that barrier up there yourself. You know, if you walk in, you make eye contact, and you have a nice, calm, you know, open demeanor about you and say, Mrs. Jones, can you tell me what's going on with you today? And you're just looking at them, and you look like you really care. And she's going to be like this. And that's what you need. Because I can talk till I'm blue in the face. Is that going to help me with my assessment? No. Your assessment is going to be based on what they tell you and what you can determine. So, particularly with the elderly or young people, get down on their level. You know, particularly if you're like a really big old person. I've told you about my old partner, Tilly. Remember I told you about Tilly? Yeah. He's a huge guy. And if he would come over and stand over somebody like this and go, what's wrong with you today? Does that scare you? It scares me just thinking about it. So if you're an intimidating type, it doesn't mean you're large. You may just be intimidating looking. You know, you have to work on that so people are not scared by it or put off by it. Make sure you use appropriate language for who you're communicating with. You're going to speak differently when you're speaking to the physician at the emergency department than you are to somebody with a 5th grade education. You want to meet them on their level. You know, you don't want to say, oh, are you having anaphylaxis? Yeah. Are you having a myocardial infarction? You know, so you need to design your communication based on who you're speaking to. Always be honest with your patient. You start lying to them, they see right through you. Particularly children. You don't want to tell them just whatever it is they want you, whatever they want to hear. So make sure that you are honest, you're confident, and you may have to take some extra time to build a rapport with the patient. If they don't trust you, if they don't believe you're there to help them, and you're really concerned for them, they're not going to tell you anything. And if they don't tell you, you can't do your job. You can't do a good assessment. You can't treat them. Try to use your patient's real name. Don't call them honey or sweetie or baby. I don't care if they're 20 or they're 2,500. Always be respectful. I know, I've had people call me honey sometimes. I'm like, not your honey. So Mrs. Jones, Mr. Jones, if she says call me honey, if you're good with that, you can call her honey. But probably the most important thing on this screen is going to be listen. Your mom told you we got 2 ears and 1 mouth, so you listen twice as much as you talk. When we're doing patient assessments, that's even more important. They don't need to hear what you have to say. You don't have anything pertinent to say. You want to hear from your patient. Tell me what's going on. Blah, 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 blah. Describe it to me. Da, 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 da. So you're asking questions, but you want them to expand their responses. So if you're constantly cutting them off and asking them more questions, they're not going to tell you anything. Anytime you've got special population patients, your handicapped, mentally challenged patients, anybody with any disabilities, hearing, visual, you may have to back up and be a little bit more patient and take a little bit more time with your patient. Pediatric patients, kids, always be truthful with them. Now, you don't need to tell them 10 minutes in advance. In a few minutes, I'm going to stick your finger and draw some blood so we can check your blood sugar. What's going to happen?
Work themselves up.
Yeah, you're never going to see that kid again. As soon as you turn your back, he's like become invisible. You'll never find him. So just you're going to have to stick their finger, get all your stuff out, get all ready, break off that little end and say, look, can I look at your finger for a second? Okay, I'm going to have to stick it. Oh, sorry, I already stepped out. So don't give them a long time to fret about what's going on, particularly if it's going to be something painful. But tell them, you know, get it all ready. I'm going to have to prick your finger, and it might hurt a bit. Prick. Oh, sorry about that. That wasn't so bad, was it? No. Yeah. Okay, your pre-hospital care report. This is your documentation, what you're going to write after you're finished with your patient, after you've dropped them off at the hospital. Now, I think most places around here are using computers. Is anybody not using computers that you know of? Now, when computers go down, you have to handwrite these. At the upper levels, I know they make you document it on the computer in FISDAP, but they also are having the students handwrite some of those. If you handwrite it, you got to make sure that it's legible. That's good, isn't it? Your PCR is part of their permanent medical record, so make sure anything you write in there is truthful, but also that it's thorough. You're going to document your subjective as well as your objective findings. So you're going to document your assessment. You're going to document what you did for the patient, your interventions, and then what are you going to document? The patient's response to all of that, right? If you've given them nitroglycerin, we want to document what? Yeah, their blood pressure, their vital signs. Did they get better? Did they get worse? On a scale of 1 to 10, how's your pain? So you're going to document how the patient was, what you gave them, and then you're going to reassess and document that. One other thing that's really important in your documentation is you're painting a picture of the scene. Once you pick a patient up at their home or at the scene of a wreck, you take them to the hospital, all the staff there sees is this patient laying on your stretcher. They don't see the car. They don't see how badly it was damaged. They don't see that there was really cold in that home, that there was old food piled up on the counters. They don't see that there's 500 different medications there at the patient's home. They don't see the environment that the patient was in. So you have to paint a picture of that. And hopefully, if you do a good job, when you first encounter the patient, they're really bad. You fix them all up, and then you get them to the ER, and they're all smiles. And the staff goes, why did you bring them here? And you go, well, I fixed them before we got here. So you've got to be able to paint that picture. This is what the patient was like when I found him. These are the things we did for him. This is how he was when I dropped him off. You have to document that because it's just you and your patient most of the time in the back of that ambulance. So if you don't document it, nobody knows what happened there. So you've got to make sure you document that. Know that that document, the PCR, is a legal document. It can be subpoenaed. That permanent record will be maintained for quite a while. If it has to be subpoenaed, that may be all that keeps your patient from suing somebody inappropriately, or it may allow them to win damages that they deserve. So it's important that you document well for your patient, but it also may keep your rear end out of hot water. So you always want to document very well. There's some administrative functions on the PCR. What's demographics? Somebody know what that is? if you're recording the patient's demographics.
It's their basic information, like their date of birth, address.
Yeah, stuff that personally identifies them, their address, their phone number, their name. Sometimes you may get their social security information. That's going to be their demographic information. You're always going to get that, and they're going to use that for what? Billing the patient for sure. You get their insurance information and that kind of stuff. That's administrative stuff. You also they're going to use the PCR for research. You know, if they see that EMS has treated this type of patient, you know, with these protocols, and they can determine what works and what doesn't work. So they'll use a lot of that for research, and that's kind of interesting and fun. They'll collect statistics. I know a service I worked at one time, they were checking statistics to see how many of the medics were successful when they started IVs. What was the average success rate for our service? And then they compared it to the average success rate for all services in the state. So that's important. If they see we're not doing a good job, they're going to call us in for additional training. And they also will track your personal experience. For instance, we just got some new protocols a couple of weeks, or about 3 or 4 weeks ago, for the paramedic level, where they're going to be able to do emergency crikes on patients, and they're also going to be able to use paralytics so they can paralyze a patient. But with that comes some requirements. In order to paralyze a patient, the paramedic has to document that they've gotten a minimum, I think it was 6 intubations within the year, or maybe it was 6 months, I can't remember. So they're going to use that to track, to make sure that they've got the experience level that they will be then qualified to do these additional techniques. So they will track that, and the state tracks all of that. They have a huge database of information that they glean from the PCRs. Your medical director will pull those. He's going to make sure that we as a service are treating all of our patients appropriately. 1 month he may pull all the chest pain patients and see if we're giving aspirin. You know, are we giving nitroglycerin? Are we putting them on oxygen? You know, are we giving them morphine? Are we doing all the things that we're supposed to do? And so he'll pull up some good calls and he'll pull up some bad calls. He'll say, these people are doing good. These people, not so good. If they're really bad, he will say, you don't have a job here anymore. On the PCR, there's going to be other run data. One thing in particular they're going to keep are times. Times can be very important. When you're in a really stressful situation and you're waiting for the ambulance to get there, how fast does time move? Like it's in slow motion. You know, you checked your time. You documented that when you left. It took you 6 minutes to get there. If the patient's like having respiratory distress and can't hardly breathe, to the family it feels like, and the patient feels like it's taking you 20 or 30 minutes. They lose concept of time. So recording these times is extremely important. They're going to record, officially, legally, they're going to record when the call came in. They're going to record when the unit was dispatched. They're going to record when the unit was en route to the call. They're going to document when you got there. They're going to document how long you were on the scene. They're going to document when you left the scene. They're going to document when you arrived at the hospital. And then finally they'll document when you were turned around and ready for the next call. So there's a whole bunch of times that are legally significant. So you've got to make sure you keep up with those things. On your PCR, you're also going to put your certification level, you know, EMT, advanced EMT, whatever. And we already talked about this stuff. Please don't put my weight on my PCR. When you're doing your narrative, your narrative is going to be your description of the call. You're going to document certain data, like you're going to put all of your times in a row. You're going to put all of your vital signs. You're going to put, you know, this document, that document. But then you have a nice space where you're going to write out and describe your call. So when you're describing that call, you're going to start, pretty much you're going to go down your patient assessment sheet. You're going to record what it was like when you got there. What was the patient doing? Was he sitting up? Was he conscious? Was he unconscious? Was he cyanotic? Was he, you know, good perfusion? What was his mental status like? Then you're going to go into your other things. These were his vital signs. Patient reported that he had chest pain, 8 out of 10. Patient says he's already taken 3 nitroglycerins. He took, 4 baby aspirin. You're gonna draw a picture of that encounter with that patient. You're also then going to give your transport information. And transport information is important. This way may be where you describe if you've gone with lights and sirens on, or if you've just gone with traffic. That may be important, it may not. If you're involved in a wreck, one of the first things they're going to look for is where you run in lights and sirens, and were you doing it appropriately, or were you just going with traffic, were you minding all the traffic laws. So as I mentioned about your narrative, you're going to give your objective information. I use a method, I think that, what's his name, wants you to use this too. Did he talk about this?
Yes.
The chart method. This really is the best method to use. Chart is going to be your chief, C is going to be your chief complaint, right? And what's the patient's chief complaint? Yeah, what he tells you is wrong with him. That's his chief complaint. Age is going to be a history of present illness. Patient complains of chest pain, for 3 days. A is going to be your assessment. I always start my assessment with objective. I'm going to do my head to toe. I'm going to document the things that I know. Patient's blood sugar was 86. Patient was disoriented. He knew who he was, but he didn't know where he was or what happened. So you're going to document the things that you can verify, and then I document the subjective. Patient says he has a headache. It's 8 out of 10. It's the worst headache he's ever had, whatever. R is going to be your treatment, what you've done. Like think of RX or something. This is what you do for your patient. Place the patient on oxygen. Did full spinal mobilization on the patient, checked the patient's blood sugar, gave him oral glucose, rechecked his blood sugar. Now it's 110 or whatever. And then T is going to be your transport information. And that's going to be lights and sirens. But right here you're also going to record who you turned the patient over to. Mrs. Jones was turned over to Nancy Smith, RN, at bedside. Patient was full report was given to nurse at bedside. Here you're going to document what you did with the patient's things. 1 full grocery bag full of medications was left at bedside with the nurse. If you've removed the patient's rings or dentures or glasses or wallet, you're going to say patient's wallet and dentures or whatever was left with the nurse at bedside. Make sure you document where that stuff was and who you left it with. Okay, that's very important, because if something comes up missing, I can tell you crack rolls downhill. They're gonna hunt for you first, before they're gonna start pointing fingers internally. So make sure you document what you did with that stuff. Document the patient's chief complaint. Here I always like to quote what the patient said. Patient said, my chest is killing me. I'm going to put that in quotes. In the rest of your assessment, if the patient says, I only had 2 beers, that's going in quotes. That old drunk said, quote, I only had 2 beers, end quote. You may have a family member that says, I saw him fall down the steps, quote, I saw him fall down the steps, end quote. Sometimes you're going to have some very pertinent, very important information that you're quoting. If you think there's something that may go to court, I will fill that thing with quotes. So it's never wrong to put quotes in there as long as your patient or whoever said it. Make sure you attribute it to whoever said it. Your patient may not tell you he was doing drugs, but the sister who was on scene may say, I saw him shoot up, or I saw him pop pills, or whatever it was. I saw him take it. I'm going to quote that. Make sure you record your pertinent negatives. Remember what those are? Who can tell me what a pertinent negative is? Chest pain that doesn't radiate. That would be a pertinent negative. Anybody else? Yeah, y'all really on this one. A pertinent negative is something that you would have expected to find and you didn't. A patient with congestive heart failure that doesn't have swollen ankles. Make sure sure if you don't know how to spell the word, don't just make a jab at it in your documentation. If you don't know how to spell it, write a word that you do know how to spell. If you can't spell apnea, say he wasn't breathing, okay? If you know there are certain words that you have trouble with, I always have trouble spelling diarrhea. I think it's because I hate diarrhea. So I always have trouble spelling that. So I had 2 or 3 words that I would transpose letters, so I just always kept those written somewhere nearby, near my clipboard, so I could always glance at it. Some people keep medical dictionaries. Tim Curry keeps a medical dictionary because he can't spell anything except Tim Curry, because those are easy. So if you know you have a problem with certain words, then write them out for you. He would keep a list. We didn't have his dictionary. He kept a long list of words, you know, that he couldn't think of, so he'd always have them right there. Y'all don't tell on me that I told, okay? Yeah. So there's nothing wrong with that, because a lot of people can't spell. But don't put the wrong spelling in there. Use another word or look it up. I mean, he calls me. I'd be home. Yeah, I'd be tired. He goes, "What? How do you spell that?" So yeah, if you don't know how to spell it, or you're not sure what the word is, don't use it. A lot of words are spelled very similarly, but they mean very different things. So make sure you get that right. You're going to be sitting on the stand, you know, with your run report, and they're going to ask you to explain what you've written, and I hope that you can do that. Your PCR, what you've written there, is a reflection of the care you gave. Remember I told you the example of the guy from Pinellas County that wrote that? Do you remember the run report? It was just the other people. Well, I've not had any fun, have you?
You don't get any good stories.
Yeah, this Maddock wrote, he had provided care for this old guy, and he was very ill, and the guy ultimately passed away at the ER. But the guy, you know, Maddock had done everything he was supposed to do, but this was his sole documentation. He wrote, that was it. That's all he wrote. This documentation cost Pinellas County $6 million. So what do you think we've got here? What does this tell you about the patient? 87-year-old male,
Short of breath.
short of breath, fixing to die, not in the back of my ambulance. Yeah, not in the back of my ambulance.
Are you serious?
Yeah, that's what he wrote. He wrote it just like this.
Is that like a correct?
Acronym? No, it's not. He made that up. He made that up.
I guess he
Well,
was tired of looking.
The guy died. His son or somebody saw this crap written, saw this written here, and they sued. $6 million, and the guy got his license pulled. From all accounts, it sounded like he gave proper care. He just did this really awful documentation.
Is FTD one that people put?
Everybody knows what that means. But it's certainly inappropriate in this setting, don't you think? I mean, y'all can talk about that on break, but don't ever put that in your documentation. Yeah, I have lots of stories like that, but I won't weigh you down with those. It's almost the weekend. Okay, bottom line is, what you write is a reflection of your care. That I just wrote on the board was a reflection of the care. It looked like that's the care he provided, because he didn't document what he did. He didn't put any pertinent negatives. He didn't document anything. $6 million. If it happened, record it. If it didn't happen, don't record it. I worked with a guy that every time he recorded, got the IV on the first stick. Really? You're the only person on earth. After a while, because he had never missed an IV, they started looking at it, and sure enough, he was probably the worst one out there, but it always recorded he got it on the first stick. I mean, that would be really nice, but it just doesn't happen. If you do something, even if it's incorrect, you need to record it. If the patient has a bad outcome from it, because you didn't tell them that you had already given them by accident 8 baby aspirin because you gave them 4 and then you forgot and you gave them 4 more, or you gave them 3 nitro and you forgot and you gave him 3 more all at once and he passed out and died, you know, you got to record that. They're going to be much more forgiving of you if you admit a mistake. than if you try to cover it up. It's like that in everything. It's like that in politics. If you admit it, you're okay. When you try to cover it up, you really get in trouble. But the way healthcare is now, they want to encourage you to be truthful so they can fix the problem. For example, for years we had several medications that came packaged exactly alike. It looked exactly alike. I know I made a pretty significant error one time. I had 2 medication vials in little vials, and they were identical. You couldn't tell them apart unless you rolled the little thing down and like read it on the side. It looked just alike. So they want to know what's causing the problem so they can fix it. So they want you to be candid. They want you to be truthful about it. And I'll tell you, they're very forgiving if you make a mistake and you own up to it, because we all make mistakes. But it's when you try to cover it up, they're going to come for you. There are some times that our documentation changes a little bit. We have to be always aware of our patient's right to confidentiality. It's a big, big deal. Don't be taking pictures of your patients on scene. Don't take pictures of that stuff. Anything that can be identified and tracked back to a patient, you can be held responsible for. With refusals, you need to really document refusals well. Remember we played some of these refusal games, all the things you have to cover with a patient before you can take a legally defensible refusal. Remember some of those? Yeah, you got to make sure that they're oriented, that they can make a legal refusal. You have to document all the steps you went through. So make sure on refusals that you write and write and write until you get arm cramps. You could spend several pages writing up a refusal and documenting everything you did. But I can tell you, if you don't, that's going to be the one that comes back to bite you. There's high liability there. Make sure you document everything. Do not falsify. Make sure you record it even if you forgot to do it. And one other thing here too, make sure you attribute properly who did what. For instance, if you come in behind the first responder crew, they have spinal immobilized the patient. I'm going to document a mobilization was provided by, St. Charles Volunteer Fire Department on scene. Or when we arrived, the patient was fully packaged. If there's some problem with the packaging or the way he's been immobilized, you want to document that. We took over care from so-and-so. The cervical collar was on upside down. I'm going to document that. I'm not going to take responsibility for either their mistakes or the things they did well. I'm not going to say I packaged that person perfectly when somebody else did it. So make sure you document who did those things. Even if it's between you and your partner at the same level. If one of you at the upper level, if one of you got the intubation and one of you got the IV, you document who did what. Okay. You respond to a call for an unconscious male. Upon arrival, the patient is awake, he's alert, and he's walking away. He states that he was just sleeping, and he doesn't need or want treatment or transport. So you got a picture of this guy? Somebody called in, passerby, and said he was unconscious. You get there, he's awake, he's alert, and he's going, not interested. Is this a patient?
Yes.
Why? Is he sick? Okay, I'm walking down the street, and my neighbor doesn't like me, so he calls 911. That woman out there, she's crazy as a bat. And they pull up, and I'm going, does that make me a patient? Just because you said I'm a patient?
Well, I mean, responsible.
Yes. Not legally. If some passerby is called, this guy has absolutely no interest in being treated. He says there's nothing wrong with me. Get out of my space. Do you have to do a full assessment on him? You touch me, I'm going to kill you? Well, no. How are you going to document this call? This is a refusal, right? Patient refused. What else are you going to say?
Call me back if you take it.
How are you going to document it?
Oh, hey, you're fine.
Patient said, I ain't sick. Get away from me. End quote. Yeah. If you touch me, I'm going to kill you.
So you
Whatever.
threatened
whatever. So yeah, if he apparently doesn't have any injuries, he's not sick, somebody called inappropriately, no, he's not a patient. You know, your service may require you to document that really as a no call, but that you did respond, you arrived on scene, patient said it wasn't a problem, he didn't call, he didn't want any care, refused any kind of treatment, wouldn't let us touch him or assess him. So I would try to get him to sign off on that. If he won't, you just have to document everything you did. And he's not interested. He's walked away. He's gone back to his house. You can't hunt him down and drag him out, right? Okay, there's some other specialty situations. This is called a triage tag. And we use this if we have a whole lot of injured patients, it overwhelms our ability to treat them. You know, if you got one unit, you drive up there, it's you and your partner, and there's 36 patients, you know, you're not going to fill out a patient care report on every single patient. You'd still be there from last week. So we have these triage calls, and we'll do a very quick assessment. We'll talk about this towards the end of the semester. If it's a minor injury, we'll just leave the thing whole like this, and we'll just jot down whatever we know, maybe nothing. We may not even know the patient's name, probably won't. You'll just attach this to him somewhere. If he's got a broken arm, we'll tear off the minor and we'll leave the yellow exposed. If he's bleeding from a head injury or has, altered mental status, then he's going to be immediate. If he's dead or almost dead, then he's going to get the deceased tag. But this allows us to do very quick care, assessment and care of a lot of patients at once. Other situations, if you have a exposure like a needle stick, or you're exposed to a patient with tuberculosis, or an AIDS patient bites you, those would be considered exposures, and you're going to have to document those in a special way. If you're injured, if you fall down the steps while you're carrying a patient down there, then you're injured. You're going to have to do a report with that. If you're on scene with a hazardous material or you're in an unsafe environment, you may need to document that. If you've been threatened with a weapon or something, you need to document that. Some situations you may have to make referrals to social services. Usually that's done through the emergency department. You would document that. And of course you're required to report any type of abuse, elder abuse, child abuse, that sort of thing. Has to be domestic abuse, those have to be reported. Pretty quick. What else has to be reported?
Weapons,
No, we don't have to report. We don't have to report weapons, but we do have to report.
drugs.
No, don't have to report drugs. What? Y'all say it at the same time. I can't answer.
You say
Threats? No, you don't have to report threats, really.
Violent crimes?
That's the same thing.
Yeah, gunshot wounds, knife wounds. You have to report those. Those are reportable. One other thing I've reported a few times.
Dog bites?
Dog bites, yeah.
I have been bitten
Dog
by a
bites.
dog and rabies shots, freaky stuff.
I'm sure that would be true. Okay, your radio report. Make sure it's got your level, your provider level, when you're going to be there, your patient's age and sex and chief complaint. What does this next one mean? Pertinent HPI. History of present illness. Yeah. Any major past medical illnesses, provided they're pertinent. Patient's mental status. You always want baseline vitals. Y'all don't leave yet. I have to stay till the end. Y'all have to stay too. Because if you don't, I may have to create a quiz. It will be nasty. Okay, PCR. This is your demographics, right? You're always going to put your nature of illness, mechanism of injury. It has to be on there. How the patient was found, where they were found. Were they in a building somewhere? Were they at home? What?
You said you have to get at least 2 vital signs, or is, like, you don't see the fire department using one, and then you go to another one, does that count? Or you yourself have to get 2?
That's a good question. You have to document 2 sets of vital signs. For me, I'm going to document my personal vital signs because I know for a fact that if I took your blood pressure, I could recognize if it wasn't 120/80. But there's going to be many times where somebody that's gone ahead of you that's not real experienced, and they're going to give you a set of vital signs. The patient's got a pulse of 80, respirations of 16, and the blood pressure is 120/80. And you're going, really? You want to get your own. Could you use that? In a pinch, I've gotten a starting set of vital signs from the nurse where I transfer a patient, or, you know, if I only had time, I got one, then I may pick up the vital signs that they first get at the ER or something like that. But you should get at least 2 sets of your own. I wouldn't tell you to, of course, never make them up, but I would just be careful about taking somebody else's vital signs. Because what if you took somebody's, you wrote it down, and they said it was 120/80, 10 minutes later you check it, or they check it at the ER and it's 188/110. How are you going to feel? That would be the big S word, yeah. Yeah. Okay. Recognize a PCR as a legal document. We use them for research. Make sure that your report paints a picture. Those people have not seen what you've seen. So you need to make sure you accurately describe how the patient was the whole time you had him. Bedside report. Okay. Make sure you organize your thoughts in your head. When you write, anything that you write, even if it's a report, if you're writing a paper for English class, you're only going to write what comes out of your head. And if your brain is scrambled, your writing's going to be scrambled. So it's important that you try to be organized. I'm going to do that. Y'all can do that. You can pull this up and do it at home. Alright, y'all don't need to turn this thing off because our recording hears you.